the city.
Well, welcome back, everyone. This session, we're going to talk about the social determinants of health. And for those of you who don't know what that means, that's okay, because it's confusing. It really doesn't have to do necessarily with medical interventions to improve health outcomes. It's those non-medical interventions, according to the CDC, that will help determine how healthy you are, perhaps what kind of life you'll live, or maybe even how long you live. And one of the things that you want to focus on is zip codes, like where were you born? Where did you grow up? Where do you work? Where do you play? You want to talk about things about food access. Is it healthy? Mental health, are there services? Is it being dealt with? And we're so fortunate to have organizations here to my left that can talk about all of these things and the difference that they are making in communities all around the country and in some cases around the world. So if we could start with introductions. To my left, it's Dr. Kaleni Jabrea. She's the Chief Health Equity Officer at Deloitte. Next to her, Derek Perkins. Derek is a Senior Vice President of Bank of America, and he's also the market leader here in Washington, D.C. To his left is Cynthia Germanata. She is the president and founder of the Born This Way Foundation. For those of you who have heard of it, just know that Lady Gaga is her daughter, and they founded it together, and they're making such incredible progress in helping the youth of America and the youth of the world around mental health. And then at the end, Apu Patel, who is a former colleague of mine from the American Red Cross way back when.
Yeah.
Yeah, he runs social impact here in the US for Novo Nordisk. So that's who we've got. It's a powerhouse lineup. And I think, Kaleni, I'm going to start with you to talk about what Deloitte has done to help individuals, but also help communities in this health space and how it relates to the social determinants of health.
Yeah, thank you, and thank you all for being here. It's been a great session today for me, sitting in the audience, learning from all the stories that others have shared. So as you mentioned, I am a physician, and I always say I'm a cynic, which is an idealist with a broken heart, right? So I started out my career in public health, then practiced medicine for about 10 years. And when I tell my physician friends I'm at Deloitte, they're like, what are you doing? Like, what gives, right? And so for Deloitte, we believe in health equity for, I would say, kind of like two simple reasons. One is that we have a strong belief that health equity is a moral and a business imperative, that they're not separate and distinct. The other component is that while some people like to think healthcare is something that doctors do or life science organizations, health plans, we believe that any business that employs people and pays for their healthcare benefits is actually in the healthcare business, because the choices that business leaders make impacts access or lack of access and barriers to care. And I love what you said, which around health and well-being does not start at the doctor's office. It starts at home, and you can make it accessible to all, right? So when you talk about social determinants of health, we speak to them as drivers of health, which are the social. We know loneliness actually leads to lower life expectancy. LGBTQ plus community has higher suicide rates, right? So social impacts. Environment, strong links between asthma, cancer, life expectancy, depending on where you live and whether the air is clean, the water is clean. And then economic. If you look across the country and quite frankly across the globe, the one factor that can be most easily traced to health and well-being is financial health. So what are we doing at Deloitte? We're really focusing on three things. One is that we are activating leaders just like you. We have a number of partnerships, so we can talk about that later, but really partnering with the business ecosystem to understand not just how big and great the problem is, but what can we do about it. Very action-oriented. The second is we're doing a lot of research. We've quantified the cost of health inequities and health disparities and what it means. And then the third is we're looking at the structural flaws in how healthcare is delivered and financed. Once again, the takeaway being we'll pay, and I was an emergency room doctor, we'll pay for someone $100,000 million to do last-minute interventions, but we won't pay for healthy food or a safe place to live. And so we're tying the dots to have a business case for taking action early and upstream.
Yeah, thank you. And Derek, just like with Deloitte, people say, why is Bank of America up there? But there's a really good reason for it, right? And particularly around financial health of individuals and how that can impact their physical health.
Absolutely. So, this is actually a perfect sort of lead into the work that we're doing. We realized during sort of 2020, during the COVID, that there was an opportunity for Bank of America to be in that space where we are in, we're around almost every community in the country. We have associates in those communities. We want to be impactful in those communities. So what we thought was, well, how does Bank of America, who's touching all of these, every 1 in 2 households in this country is a Bank of America customer. And so how can we be impactful in the communities? So what the bank decided to do was identify 11 communities to do a pilot, one of which is DC, to really go deeper. How do we sort of close some of these health disparities? Like here in Washington, D.C., there's about a 20-year age gap between Ward 8 and Ward 3. Like, why is that? Like, how do we help lead into that space? We're clearly not in that space. So what we do is we convene people who are in those spaces. We're partnering with American Diabetes, American Heart, and American Cancer, and the University of Michigan to really help drive this work and really help influence this work. We also realize in that we have this affordable housing portfolio. Like, how do we help address some of those health disparities that are present in folks that are living in our affordable housing communities? How do we help drive that? And again, we're Bank of America. We don't do those things, but what we do, we have convening power. So we work with our partners to help drive this work, to help improve better outcomes. This is a 4-year plan. We're 1 year into it. We're willing to really look at access and activate and also lobby where need be to really help get change policy. The doctor mentioned sort of the work that needs to be done. Like, you're willing to spend monies on sort of healthcare treatment on the back end, but not on the front end. And the question is, how do we help shift this type of behavior? So we want to help drive those throughout our communities in which we live and work and play.
Thank you for that, Derek. And Cynthia, we've known each other for a while. What the Born This Way Foundation has been able to accomplish, particularly focused on youth, and particularly focused on improving their mental health, can't be really, it's just amazing what you're being able to accomplish. Can you explain how that all came to be, where you're able to use the power of celebrity and message and voice to really drive home real change in the mental health space, which affects everything else?
Thank you, Mark. And, Born This Way Foundation is something that's very personal to my daughter and I, and also our family. Mark mentioned that, we have worked together. Before Born This Way Foundation, I spent 25 years in the corporate world, and I've had the privilege the last 12 years of working at Born This Way Foundation. But I am first and foremost a mom. People know my daughter as Lady Gaga, but to me, she's my Steffi. I have another daughter named Natalie. And our work is the result of her experience with a mental health journey that began in middle school. And it's a very long story, but she and I both noticed the absence, really, of 2 critical things during that time that I guess we would call social determinants. One was a safer and a kinder environment that supported her when this was happening. And second was the lack of mental health resources, education, training, where do I go for support? And these were 2 very critical things that I believe and she believes could have really made a difference in her mental health journey. And because of that, she became very, very passionate about ensuring that other young people felt better equipped. We heard from young people all over the world that they prioritize their mental health very, very highly. 9 out of 10 young people do. Yet they don't have the resources, they don't know where to go, they're concerned about quality of access, trusted services. So our work really focuses on that intersection of kindness and mental health, and in a couple of buckets. First, we reach young people through a number of kindness campaigns, and then we engage them in various types of training to support themselves and also one another. So we have that individual aspect, but there's also a community-based aspect where we invest in community-based nonprofits that are already providing mental health training to young people. So that is really where our work lies. We have learned through our research, we're very much a research-based organization, that young people who report living in kind communities and being in them, whether it's schools, their homes, the fun places that they go, they are mentally healthier. So it's critically important to us. We've all seen the statistics. We know the dire straits that young people are in now. Kindness is free. It's something we all have to give. As my daughter says, it's priceless. So we believe very strongly that it's up to all of us to support our young people.
And Cynthia, could we just follow up a little bit about what you said about that connectivity between kindness and mental health? Because for our generation, people didn't talk about it. And it was stigmatized.
Right.
And that's not, because of the fear of the stigma, right? There's that, I guess, kindness didn't exist at that moment, right? Where people were not nice about this. And we still see it today, but not as much as we did before. How did you make those two connections and really just drive it home through messaging?
I mean, a lot of it is awareness,
Yeah.
And one is getting that research out there that we do know that empirically that a kind environment will affect young people. So that's one of the keys, is just the messaging around the awareness, and also, testing various of our programs in communities. Much of what we do is driven by what young people tell us. We don't really develop any programs, whether that be kindness campaigns or peer-based education, without asking young people. It's important that their voice be present, that they hear the work. So they are really driving this messaging around kindness. We did a study of young people coming out of COVID, looking at how they viewed kindness, how they experienced it during COVID. And despite the very difficult times of COVID, they believe that kindness is the path forward. So that they hold that key to creating a better mental health environment for themselves, and they want to do it. And it's up to us to support them and equip them with the tools.
Yeah. Thank you. So, Apu, when we think about health, we think about companies like yours. But it's not just your products, right? It's the core of the company is really pushing forward all social determinants on many different levels. Can you talk about kind of how a truly healthcare company is engaged in promoting the social determinants of health in a non-medical way as well as a medical way?
Yeah, thanks, Mark. Novo Nordisk, as you said, is a healthcare company, and so it's in our DNA to be involved in health programming. What I think makes our philanthropy a little bit different than our commercial side is our commercial side is really focused on the patients. And so we're always interested in patient outcomes and patient health. On philanthropy, when we created our strategy in 2021, it was where do we go and how do we work in communities that are most vulnerable to prevent the disease from ever coalescing or happening, right? We're focused, we're a diabetes, obesity company, we work in chronic diseases. If we want to go into the communities where chronic diseases are most prevalent, the Black, Brown, Native American populations as an example, how do we work in those communities to prevent their extremely high burden, disease burden, from ever happening? And so I think we started thinking not patient health, but community health. And when you start thinking primary prevention in those communities, you're forced to think about social determinants of health. You have to think about physical activity. You have to involve and invest in food access. And so I think as we start looking at our portfolio, I didn't think 2 years ago we were going to be as heavily involved in food as we are. But even food is so complex and the social determinants of health are so complex that it's hard to just focus on one. You almost have to focus on everything that we've all talked about on this panel already. You've got to focus on housing. You've got to focus on mental health. You have to focus on transportation and economic empowerment if we're going to deal with the problems and improve community health outcomes and avoid or prevent some of those chronic illnesses from coming up. So for Novo, it was kind of an easy decision. We knew we were dealing with these chronic diseases, but I think we were really pushing this idea of how do we interrupt business as usual for us? How do we think about kind of reimagining some of the assumptions we were making and looking at primary prevention in communities that we just hadn't looked at before?
Can we stick with the food as medicine concept? And you've made tremendous investments in that here in the U.S. Could you explain what you mean and how you do that to the audience?
Yeah, so we cast a much wider blanket around food as medicine than I think a lot of other organizations. We don't believe food is medicine only in a case of a clinical setting where a doctor writes a prescription and says, you need to eat a medically tailored meal. Food in general is medicine, right? And so as long as we can get people eating healthier more consistently, getting involved in physical activity more consistently, I think that's really important for us as that primary prevention step. Because we want to deal with populations as a general population and not a patient population, I think it's really important for us to push in that direction. But I think, Mark, to your point, we're realizing the situation with food and food access in many communities in the US is super complicated. We're dealing with issues around food supply, food distribution, and food consumption. It's pointless to have healthy food out there in the community if no one's actually eating it. And so we're getting involved with our investments in this kind of multi-interventional approach where if we look at a community and we take on, let me take a step back. Most of our investments are a place-based investment. In other words, we are finding partners in the communities and places we want to invest that understand that population better than we do. They're working with the local stakeholders, they're working with the local residents, and they understand the challenges and can come up with solutions better than we can. Cynthia talked about this too, finding those local nonprofits that we can invest in. We're investing in them, and then we're looking to creatively design interventions that make sense for that community. So in Philadelphia, there are 26 partners that are in the umbrella of the funding that we're doing. And those 26 partners are doing everything from faith-based education, so going to the churches where people trust that situation more than they might the formal healthcare system, layering on food access, layering on mental health services, so giving people who are suffering from chronic diseases or exposed to or maybe suffering from chronic diseases an opportunity to share their stories with one another and create that kind of peer connection. We're working on food access and economic empowerment so that people have money in their pocket and they can continue to invest in healthy lifestyles. And I think that multi-interventional approach is what we need more of. And I know for a fact Novo can't do it all. So how do we as organizations and as companies come together with our different priorities, but they're all speaking to community advancement, and how do we start investing together? And so I think that's where a lot of our focus has been, is this multi-interventional solution that's kind of driven by our community-based partners.
Yeah. And Derek.
Oh, I'm sorry. I was going to
think you were thinking the same thing,
right? Because what Apu talked about is what we're trying to do. We're sort of pulling together these partners. We're taking in our community members and we're listening to them, and they're telling us what their challenges are. Food access is at the top of the list. Yep. But to that point about getting better food access, we're bringing in partners who deliver that. But if you get something that is healthy, but you don't know what to do with it, now what? So we're also bringing in partners to show people how to prepare it, right? Like we want people to actually have the food and eat it, but it is bringing together a set of partners to really talk through, this is what the community outlined that they needed. And so we talked about, we had a community meeting several months back, and one of the things that was pointed out was that people don't feel safe. Right, like so now we have to, because we're saying, hey, you should walk more, but they don't feel safe walking in their neighborhood. So how do we help address that, right? And that's from an intervention standpoint, that's sort of working with the cities and the counties around to make sure that we create safe environments for people. Once we create safe environments, it's getting that food access. It's knowing what to do with that food. And then it's also helping folks understand sort of medical diagnosis. We're doing that as well. We're bringing in partners. Once you get this diagnosis, what does this mean? How do I help improve it? What are the things that I can control in my household? And so we're trying to pull all these partners together. You have 26 partners. We're not quite there yet. We're probably around 6 or 7 in our communities. But again, it's going to take sort of a coalition of people. And this is why I think it's really good that sitting up here, we have representation across different industries and different sectors, because I think it's going to take all of us to help drive this forward in this country and help close some of those health disparities that we see right now.
And Kaleni, the 3 organizations to your left, they all have superpowers, right? And Deloitte's superpower is really about consulting with clients and telling them what to do and how to do it best. What do you make of all this as the Chief Health Equity Officer?
Yeah, thanks for that, Mark. And my superpowers are in my shoes, by the way. A few of you said you liked them earlier, so thank you. So the way we think about it is we really try to focus on empowerment, right? So everything that Apu, Derek, Cynthia have said, it's completely relevant, and we help solve for those issues as well. But one of our superpowers is really to say, okay, let's trace the money and the root cause of why is there a food desert? Why doesn't somebody understand the medical diagnosis they got? Why? And there are three things that we've identified as being the root causes of what's driving, so most upstream. And I've been counseled many times to start with the first one third, but I always start with the first one anyway, which is first and foremost, we all have to acknowledge that racism and bias exist in society and they exist in the workplace, right? There's data that shows it. It's not calling any single person or any single organization a bad name, but it's out there, right? I think the second thing that we need to understand is everything we've been talking about, the social determinants of health, the drivers of health, where you become an object in your life instead of a subject, right? So imagine, we just published a paper that talked about the pink tax in healthcare. So we've all seen the wage disparity that exists. Women get paid 80 cents, 70 cents, maybe sometimes 60 cents on the dollar. We also know that there's a pink tax on the lotions, razors, you name it. We found out of pocket, employed women pay $15.4 billion more a year per person for their health care. So we did a deep dive and said, why is that? It's because of how benefits are designed, how cost sharing is designed. So while all preventative services are covered, you do a diagnostic mammogram that's covered, now you've got additional tests that need to come out of pocket that you don't have the money to pay for. And oh, by the way, you're a shift worker and you've got childcare and adult caregiving responsibilities that you can't even get the time to go off, right? So those are the determinants of health that kind of multiply in each other. And then, Mark, as I mentioned, we work a lot. I have two hats at Deloitte. I'm the Chief Health Equity Officer. I also lead our life sciences and healthcare consulting practice, which means including Apu's organization, but all the pharma companies and all the health plans and care delivery systems on how do we solve for these things without making false choices? So worked with a local healthcare system actually that was looking across the board saying, supplier diversity, where do we cut costs? And we showed the CEO the data to say, the best way for you to cut costs is to close all your services in this part of town because they're mostly Medicaid patients. It's hard to get the workforce that you need, but here's the human toll that will happen. And we had a frank discussion and said, the easy thing is to just cut this out of your portfolio because it's costing you money. The longer term and potentially thing that you can do with business partners and the government and CMS and HHS and your local health department is to take the longer track road where you actually solve for having education brought, hiring skilled workers instead of those with college degrees, bringing food trucks to the places, providing transportation for the kids to be picked up, right? And so what we do is we try to be very diligent about quantifying and measuring and naming the things so that business leaders have options to make with a fully informed set of impact that they have. So simply said, I think we go from looking at it from a bottom line, just EBITDA margin, to saying what's the sustainability and stakeholder impact. And we can help you do the math, and we can actually help you navigate past the roadblocks that may exist.
Yeah. We're going to get to measurement before we run out of time, but I do want to talk about empowerment. And Cynthia, your Be There certificate that you helped create, I've gone through the course. It's helped a lot, right? It's empowered me to talk to my kids. I have a 17-year-old and two 13-year-olds, so you can imagine what my house looks like every night.
My condolences.
Thank you. So, but tell us more about the Be There certificate and how you're empowering people like me and the youth to be able to identify issues, learn how to deal with them, and now you have an army of certificate holders who can really make a difference in their own families and in their communities.
First, thank you for taking the certificate. I took it as well, and it immediately helped me have conversations with my daughters, as well as other young people in my life. So, what Mark is referring to is the first ever certificate-based mental health training that's online. And I mentioned earlier that young people, they very much prioritize their mental health. they want to help themselves, they want to help one another, but they don't have the resources and the skills to do that. And we partnered with a company in Canada called jack.org to co-develop a peer-based mental health training. And it came about from a substantial body of research where they talked to a lot of young people about where do you currently go for mental health support? What do you use? What do you Google? And what's missing? And it were those gaps that we were looking to fill. And for example, a couple of those gaps were things like the right support to break down the stigma around mental health, a much more inclusive type of training that would be in multiple languages, that would take into consideration disabilities, different identities, people with chronic illnesses. So all of these factors went into this wonderful training, and it's a 90-minute free, self-paced, peer-based mental health training that teaches you how to have the right conversations about mental health, how to ask the right questions, how to know your boundaries when you're having those conversations, and most importantly, how to connect that person to proper support. And it is self-paced, so you can kind of stop and start at your own will. It's incredible. We have, in fact, just based on the work that you do, we partnered with an organization, corporate organization called Cotton On. I don't know if you're aware of them, but they're an Australian lifestyle brand, clothing and other merchandise. They too want to bring additional mental health training to the world. And so we've invested $5 million this year raising funds to expand the training. We've already had over 30,000 people take the Be There certificate, and we're looking for, obviously to expand that more. And it will be through these types of conversations where, you don't have to be a young person to take it. I think if you have a young person in your life, if you're an advocate for mental health, it's something that would be very, very rewarding and gives you the confidence to have those conversations. And we're also seeing a number of colleges, for example. We know from our research that when young people are in times of mental health crisis or having an issue, they would prefer to talk to a peer. But the peer is not properly equipped, and that's where this training actually comes in. And a lot of colleges are actually recruiting students to be peer-based counselors. Some are paid, some are unpaid. But it's also a source of altruism, I would say, for young people, that they also feel good about having that knowledge and also helping their peers.
And Cynthia talks about Jack in Canada and Cotton On in Australia. Derek, you've got these national partnerships that you are activating locally too, right? With American Diabetes, American Cancer, American Heart. Tell us how all that kind of works from the broad top level, but also down to the communities where you have employees, you have branches, and you are seeking impact.
Right. So, as you mentioned, we have these 3 national partners, and also the University of Michigan, who's up driving the data piece of it, right? Because all of our things that we do are activated, really pushed upon the data that we've gotten from the University of Michigan. And what happens is in each market, an agency takes the lead. So in my market, it happens to be American Diabetes. They partner with American Cancer and American Heart, again, to really go into these communities and determine what is really needed. For us, it's important to have partners who understand and who listen. One of the things that we charged our partners with was ensuring that we have community conversations, meaning we have the data from the University of Michigan, we have down to the zip code level, but we really wanted to hear the folks who are going to benefit the most from the program, what they actually needed. And again, those partners drive those conversations. And I will say, as someone who participated in these conversations, out of them came things that I hadn't thought of, right? I'm not necessarily living in some of those places, so some of the things that I thought, well, they need this and that, and then they'll be fine. That's not how it works, right? I'm not living their day-to-day life. I'm not thinking about childcare pickup. I'm not thinking about how we're rolling out this programming. I'm not thinking about, do you need elder care? Do you need child care? Like at our community meetings, we allow children. And we did them later in the evenings. We're moving them around to do some in the mornings, right? Because we felt, in order to really capture the population we wanted to really impact the most, we needed it. And again, our partners, American Diabetes and American Heart, are really driving this work. We're focused on heart cancer, and diabetes, because from a sort of premature death cause, these are the leading causes across Black and Brown and Native American communities. So we want to make sure that we are impacting those 3 segments of the population.
And speaking of partnerships, Apu, Partnership for a Healthy America is helping Novo in the food space, in fruits and vegetables. Can you explain how that's working? And perhaps there's some partners out here who could also participate in supporting your efforts.
Yeah, I mean, I think, we've kind of heard the term collective impact, and I think when we find partners like Partnership for a Healthy America, it makes it easier for us as a business community to kind of actually practice that collective impact. And so PHA, after the White House initiative, there has been a lot of folks talking about food and food access in this country. And I think groups like Partnership for a Healthy America were able to kind of set bold, ambitious statements out there and saying, we want to double the amount of produce consumed in 15 cities. And it's easy for Novo to say, we want to join that. And we want to get involved in that because it speaks directly to our philanthropic strategy. We want people to eat more healthy food consistently. And Partnership for a Healthy America is able to bring us together along with several other businesses, Instacart, many of the major retail organizations that are selling groceries, fund foundations, and others to come in and saying, let's all collectively invest together and change the way people are eating in these 15 urban markets, and hopefully more as we go and expand. And I think those are the kind of partnerships that we want to see created more of. For Novo, all of our projects are kind of this, 2 years ago when we started this investment strategy, we're now, after 2 years, in 26 projects in more than 16 states, and our portfolio has surpassed $35 million. And that, we're proud of that, but I think it's still a drop in the bucket when you're looking at issues like social determinants of health. And so if we can't invest that with other corporations and other businesses in a collective way, it becomes somewhat meaningless, right? We don't have the impact that we're all, I think, on this stage trying to achieve. And so, groups like Partnership for a Healthy America, if that's the way we convene and bring our resources together by utilizing the right partners in the right places, I think that's really important for us to think about.
Lenny, I know you're dying to say something. Go ahead.
No, I mean, I'm so aligned with how you all are thinking about partnerships and collaborations. We launched Deloitte Health Equity Institute in 2021, right when COVID started. And if many of you remember, on the news every night as people were reading COVID statistics and how Black and Brown communities and rural and poor communities were being impacted more, we had a number of organizations that said, they don't trust us, they won't come, right? And we actually did a double click and realized it's because the hours of operation don't make sense. There's not transportation to get to where you need to go, and the person they trust is someone in their community, not necessarily the doctor or the insurance company or the politician, right? So our first project in terms of collaboration were with a number of healthcare systems, including Common Spirit Health, which is in 22 states, and we touched 100,000 lives, gave out 10,000 vaccines in a 2-month period, right, which was fantastic. So then we said, what can we do more of? We worked with the American Hospital Association to actually create a reference guide of how do you make health equity a board agenda topic. So we created this one-page reference guide, and then all these hospital systems came together and said, we want more. So we created a full playbook, and this playbook, all of this is part of our pro bono work, by the way, so it's available to the public, so anybody who's interested.
How do they get?
So if you go to AmericanHospitalAssociation.org and just look up Health Equity Workbook, you can find it. And Kaleni Gabrias just link me in, and I'm happy to also share that with you. And then I'll mention 2 other offers actually to this great group, which is we also worked with World Economic Forum. We have over 500 global CEOs and organizations who've signed up to have a zero health equity gap. We're building out a framework that looks at your health footprint the same way we look at carbon footprint, right? So it's actually looking across the board, whether it's climate, housing, transportation, to say, what is your organization's impact on the health of the communities of your workforce and the communities? Because quite frankly, the biggest myth I often hear, which goes unsaid, is that health equity and social determinants happen to other people who may not be employed or maybe somewhere else, and it's actually part of our workforce, your workforce. And maybe the last one I'll mention, Mark, is we just launched a big campaign with American Heart Association and the Society for Human Resources Management. I believe in goals. We have a goal of 10 million lives by 2025, at least 10% of the American workforce. We've created, once again, a playbook. It's on the American Heart Association's website, where we're activating the CEO groups and specific actionable things for human benefits to do, for business leaders to do, so that it doesn't just become this problem that is larger than us. And you talk about it at a cocktail party, kind of feel better, go to sleep, wake up, and then you're like, now I get back to real life, but that it becomes part of real life. So that's also available.
So how do we know that we're making progress? And Derek, how does Bank of America kind of measure these efforts against your goals? How do you know if you're moving the needle? And I'll ask, not just you, Derek, the entire group, because that's sometimes the hardest thing. And if you're not, how do you pivot, right, to get to that place where you are making a difference and you can actually validate that?
This is where the University of Michigan, from a broader scale, is really helping us, right? We're looking at sort of across those 11 markets, we're looking at our captive population, and we're looking at sort of down to the zip code level of, all right, when we started this work, these health outcomes were this. This is what we expect over the next year, 2 years, 3 years. What we are realistic about is that we don't expect to solve this within 3 years or 4 years. This is actually an ongoing sort of a change in the way we deliver in our local market. So this is going to be an ongoing strategy. It's going to be a collective effort, right? Like, I love what I'm hearing on this stage, so you should look for my email coming pretty soon, because I feel like, again, we can sort of leverage some of the things that they're doing, but it's looking at down at the zip code level, and looking at the positive health outcomes. Are we getting more screenings? With those screenings, are we getting diagnoses that are different? Are we changing people's lifestyle? So that's sort of how we're sort of incrementally measuring this at the top of the house, but then also down at our local level. We're going to look at, what does that look like for DC? What does that look like for San Antonio? What does that look like for Memphis? What does that look like for Chicago? Again, across certain zip codes that we sort of deem sort of the most challenging and the ones that we really want to lean into the most.
And Cynthia, how do you know it's working?
The youth tell us, honestly. I mean, we believe really the greatest barometer is young people. That's our audience. I would encourage anyone doing impact to ask the people that you serve how it's helping them. Ours is very much an iterative process. I would say first looking at what does success look like, and that's where our research comes in. We ask the young people, what are the gaps? What do you need? And that goes into every program that we develop. And then secondly, we measure the impact of our programs by our reach. That could be digital services, impressions, many types of metrics there, and engagement. Completions of the Be There certificate, for example, number of organizations that we're invested in, as well as the impact that they have in their communities. And then I think closing that loop, that's part of the iterative process, is youth culture changes quite often, and we have to keep up with it. So we're constantly kind of revisiting that, and asking young people what has changed. I know certainly myself as an adult, I would distinguish between online and offline. Young people don't, so we know that we have to meet them wherever they are, so our services have to sit across all of those platforms. So it's really based on what the young people are telling us.
And Apu.
I love this question.
Yeah.
I think part of our strategy when we thought about measuring impact meant we had to start investing in longer periods of time. You can't invest for 1 year and then hope you're going to achieve impact. So we had to do multi-year funding. And we're doing 3-year funding, and I would tell you, all we're going to get after 3 years is basic outputs. Number of people that we might have served or reached, maybe number of servings of food. But I can't tell you we had a health outcome impact. 3 years is way too short. When we started, we said, wouldn't it be great if we could measure reductions in A1C or reductions in waist circumference? I no longer believe that, right? And we're learning as we go. Now if our partners, and we got to find the right partners, because it's not Novo's job to do the measurement. It is the partners that we're funding that have to collect the data. And all grant partners, all nonprofits, all community-based organizations you're working with, we need to ensure we build their capacity to do basic monitoring. To your point, Mark, can they even collect the output data? Can they collect the data about people being served, what meals and when? Because that's important. Because if they're not able to do that, then we need to go back to the drawing board and saying, wow, that training session did not work. Most of the people who left that training session didn't learn anything because you were speaking in French and they understood English. And so maybe we need to go back and figure out a different delivery mechanism. So monitoring, I think, is super important for our grantee partners just to understand if their delivery is effective. And now, I think when we think about longer-term impact, we can't think about, I'm going to solve the I'm going to prevent chronic disease in Philadelphia question. What I would like our grantees to start measuring in the outcome world is there more access to healthy food? Is there more opportunity, as Derek was talking about, to provide physical activity or places where people can be physically active? And ultimately, and I think this is where we have to stop, is are they eating healthy consistently? I don't need to reprove the science that says healthy eating and physical activity lead to health outcomes. It's done. There's tons of research out there and white papers out there. So why do I bother my grantees in saying, prove to me that you did this? If they can prove to me that people in Philadelphia, people in DC, people in Houston are eating healthier more consistently in the communities where we're working, I'm satisfied. But that is not a 1, 2, or even 3-year question. That's a 5-year question. So we as the funders have to be really patient about the data we're expecting our grantees to collect and deliver. And I think if we can find that patience and we can find that the ability to wait for that impact to happen and stay true to our strategies, we may actually achieve something at the community level.
So Glenn,
I was going to say, I would just add to that, right? It's why we're sort of scaling these things down to the very local level and really going to some of the housing, because again, you're not going to get these outcomes that you want in 1, 2, 3 years. It's going to be a long-term process, and it's like, how do we sort of identify this community? We're going to go into this community, right? Which is why I think it's good that there's multiple people working on this one topic, because again, it's going to take all of us to help drive it, and it's going to take a long time. And we have to be patient, and then as a business community, we have to be patient, right? Because some of the gains are on the back end of it, right? Like, so there's a little bit of cost now, and you're going to get more gains on the back end, and sometimes that's hard for us because we're looking at the dollar today and not the dollars that you save in 3 years, and 5 years, and 10 years, and 20 years.
Yeah, and I agree with everything they've said, with a caveat that I don't get paid unless I show the dollars today, even when it comes to this topic. So I fully agree that, we do a lot of can we measure that we did as we said and we said as we did, right? We started out with $3 million of investment, $25 million the next year, and now we've committed $1.5 billion over the next 10 years on 3 things that we believe that are multifactorial to accelerate the outcome that we talk about, which one is health equity, which is everything we've been talking about. The other is workforce development and education, because ultimately we believe unless you have economic mobility, this philanthropy work, we're just kind of like patting ourselves on the back, right? And the third one, financial inclusivity, which you'll get my email too, right? But just how we can use those 3 things so that we're doing what we say. And then the second part of what we're doing, and this is where it gets really complicated, and there are a lot of assumptions, and it's not perfect science, but we try to actually quantify and estimate for every dollar in housing that you invest in housing versus every dollar you invest in smoking cessation versus food access, like which combination and which one thing seems to make more difference for which community, right? So cause and effect. So we're a little bit like geeky about it, and we have a tool that we're like, I'm going to tell you, this is deep state. We have information on every household in America, which we do. But we literally look across communities to understand, like, what's the magic combination, with the assumption that it's not the same thing for every community, but we have to continually analyze. And the last thing I'll say on this is, we always assume for each one of these things, we're going to get it exactly wrong every single time. So we're just constantly learning and pivoting and refining and modeling.
Yeah. Well, we're almost out of time, but I want to give each of the panelists the opportunity to answer this. If you had one wish for this audience to help you, what would it be? Apu.
invest with us, invest in the partners that we're finding, because I think we're all investing in some really important sectors, but I think all of those contribute to the ultimate community health outcomes that we're all looking for.
Very similar. I would say please collaborate with us and do so with a long-term mindset. Changing the landscape in mental health or any health really is a multi-year, multi-investment commitment. So yeah, collaboration and long-term.
And I don't really have anything different. It's really about collaboration and being patient in this process, and long-term investment. Like those are the things that we really need to partner with, and then not recreating the wheel. There's a lot of good work that's already being done. Let's figure out how we can all plug into it and drive it forward.
Yeah, and I think I would go beyond the headline of the big commitment of whatever investment it is and invest in your workforce. Because if you do what you say you want to do for the world and the country and for the community, for your own workers who are every day watching to see if what you say is congruent with what you do, you will change the culture of your organization. You'll recruit more talented people, you'll keep more talented people, and you'll have more impact. So like everything else, I think this begins at home, so clean house before you go out and pick up the trash in the park.
Yeah. That's all the time we have. How about this for the panel?